Good afternoon, everyone. Thank you for joining us this afternoon for our next lecture in our Advanced Practice Provider series. Today is November 17th, 2021. If you are, just joining in, if you're having technical difficulties, please note the number on the screen, 919-445-1000, or you can email unclcn@unc.edu. Our team is standing by to help, so please don't hesitate to reach out. Next slide. Throughout our presentation, we will have some poll everywhere questions, and in the end, this is where you'll be able to submit your questions to Dr. Winzelberg. You can join three ways: one by the web by going to pollev.com and entering UNCCN. You can join by texting UNCCN to 22333. And then you can also join by your iPhone or Android by going to the app on your phone and entering UNCCN and clicking join. Next slide. To claim continuing education credits for this session, you will need to attend using one of the following: Zoom with the slides and the video component. Just joining by phone only without video does not qualify for continuing education credit. Other ways to participate for continuing ed is at a designated site with a site coordinator. Watching via media site does not allow for continuing ed either. And you must view for at least 50 minutes of the session to claim your certificate. At the end, fill out the evaluation, and you can claim your credit within 7 days. Next slide. So check out all of our series that we have posted on the UNC-LCN website. Our patient-centered care series, this series, the Advanced Practice Provider series, Research to Practice, and excited to announce our new series of the Southeastern American Indian Cancer Health Equity Partnership Series. Also, these are self-paced, so look out for older lectures online. You could still review them and obtain credit. Next slide. So I am beyond excited and honored to have Dr. Winzelberg with us today. I have learned an incredible amount through my practice by working side by side with him. So he will be sharing his expertise in promoting effective communication and advanced care planning for patients with cancer. Next slide. So Dr. Winzelberg directs the UNC Hospice and Palliative Medicine Fellowship Program, which has trained 13 physicians during its first 5 years of existence. Dr. Winzelberg is board certified in both hospice and palliative medicine, as well as geriatric medicine. His teaching focuses on improving communication between physicians, seriously ill patients, and their families. And he does a phenomenal job of that. So Dr. Winzelberg, thank you for joining us today. Outside of your professional bio, what's something you'd like to share with our audience they should know about you?
Well, besides being a big UNC fan, I love getting outdoors whenever I can, and actually made it to the highest point in Orange County, which wasn't particularly high compared to the western part of the state, but the foliage this time of year has been amazing in North Carolina, so that was a treat.
That's great. Next slide. So please join and participate in our poll everywhere questions. This is an example of what the screen will look like. And while you're starting to log in on your computers or phones, we'll circle back to this so you can practice. Next slide. So this activity has been planned and implemented under the sole supervision of the course directors in association with the UNC Office of Continuing Professional Development. Dr. William A. Wood and CPD staff have no relevant financial relationships with commercial interests as defined by the ACCME. Dr. Winzelberg has no relevant financial relationships with commercial interests as defined by the ACCME. Next. So our first poll everywhere to make sure your applications are working. Advanced care planning is an important communication skill for clinicians who care for patients living with cancer. True or false? So how are they doing?
It's meant to be a softball question, and everyone hit it out of the park.
Great. Next slide. So without further ado, I will turn it over to Dr. Winzelberg. Thank you.
And thank you, Tammy. Appreciate the invitation and your leadership of this series, certainly not only in working with you, but the nurse practitioner on our team in the clinic, in the inpatient setting. APPs have such a important role in caring for individuals with serious illness, and particularly those with cancer. Next slide. So just to sort of start out with the backdrop, serious illness care, including cancer care, has been in the public consciousness for years, and my sense is that it's going to continue. And really, in terms of kind of popular press, Being Mortal, which I recently reread by Dr. Gawande, who's a surgeon, was on the bestseller list for over a year, says more about the field of palliative care and has had more of an impact than perhaps a lot of research trials. When Breath Becomes Air, Dr. Paul Kalanithi is in the lower left-hand corner. That was a Pulitzer finalist, and he was a neurosurgeon diagnosed with stage 4 lung cancer. The TED Talk by B.J. Miller, who's to Dr. Kalanithi's right, has over 14 million views discussing his experience with serious illness. And then a couple of local individuals. One, Kate Bowler, is a divinity professor who wrote Everything Happens for a Reason, has since written another book based on her experience now living for 5 years with stage 4 colon cancer. And finally, The Bright Hour with Nina Riggs, who was a UNC Chapel Hill undergraduate and unfortunately died after living with metastatic breast cancer. And so to me, these are works that I learn a lot from, sort of refill my tank, so to speak, in terms of my medical soul, and I certainly advise them to you all. Next slide. So my premise is that few and likely none of us were born with bedside manner. If you're old enough, I remember seeing Dr. Marcus Welby on TV as kind of the exemplar of physicians or clinicians. That communication in its various forms, I emphasize, is absolutely a learned skill, and even thinking of it, as a procedure that really can be broken down into pieces so that we can identify best practices, actually evaluate as a procedure in research studies, and that it absolutely is a skill that can be improved with practice, with self-reflection, and then also working with others. And finally, words absolutely matter, not just to satisfaction that patients and families take away from each visit or hospitalization, but also the decisions that ultimately affect our patients and their overall care quality. And then finally, I approach this talk and my work with the belief absolutely that we are all learners. And so wherever we are, that's one of the things that I find really invigorating or challenging about communication is we can all improve on our skills from patient to patient. Next slide. So even to start out, this is a terrific resource by the American Society of Clinical Oncology, which published a guideline now 4 years ago on patient-clinician communication. And they started out asking the question, what communication skills and tasks can clinicians use to optimize the patient-clinician relationship, well-being, as well as family well-being? And just to give you a sense, they reviewed, and this is specific to oncology, almost 50 publications over a 10-year period, came up with 30 recommendations in various topics, not just core communication skills, which I'll outline shortly, but specific what I reference as procedures, goals of care, prognosis, even talking about clinical trials, and then end-of-life care. And so if you're interested, it is actually a good read to learn more about what experts in the field of oncology are proposing. And I think the other piece is, this is obviously unidirectional. I hope we may have some questions at the end, but what I would emphasize is that training absolutely has been shown to improve quality, and it doesn't require a full week-long, CME course. Even smaller amounts, 7 hours, or more recently, even less amount of time, can help improve someone's skills. Next slide. So one other slide before I start, in the spirit of Oscar Wilde, imitation is the sincerest form of flattery. Some of what I'm going to share has been modified with a couple of main resources. One is an organization called Vital Talk, and so the website is there. It was founded by a group of physicians, including oncologists, who strive and do research on communication. And so there are a lot of free resources that I would point you to, actually including an app which can help prep someone before a family meeting or a communication event. And then Ariadne Lab is actually related to Dr. Gawande, who I mentioned previously. And one of their areas of emphasis is on serious illness care, including communication. They have developed a guide, which I'm not going to directly present today, but we'll touch on some of the aspects of it. But that's a tool that you are welcome to access, and to join that community, it is also free. Next slide. So my objectives in our time today are to both identify and then help you envision how to implement general strategies to improve communications for those living with cancer, to then get specific about advanced care planning and defining some of the components, as well as describing a framework for how we can engage in advanced care planning, particularly in the clinic setting for individuals who are living with cancer. Next slide. So here's our first of 3 questions. Prior research demonstrates that clinicians, specifically physicians, during family meetings, A, speak for fewer minutes than family members during these meetings, B, speak for about the same number of minutes, or C, speak for more minutes than family members. Give you a few more seconds. Well, good. I'm glad there wasn't complete unanimity on this one. Wasn't meant to be a complete softball. Okay. So the clear majority would say C, more minutes, and a little bit thinking about fewer minutes. The correct answer is C, and let's move on to the next slide. So the first premise that I'll share with you is clinicians, and again, most of the research is specifically about physicians, so I don't want to cast too broad of a brush in terms of the APP community, but I'm working off what we have in the published literature, that clinicians talk too much compared with patients and families. And why is this important? I think the risks are, when we as clinicians are dominating the visit in terms of talk, we have less of a chance to understand what is on the minds of our patients and families. We don't get a sense of understanding, probing what their health literacy is, and we may risk undermining trust or not having as much opportunity to build trust. And the study, which is now amazingly almost 20 years old, but really is a landmark in the work of communication, involved audio recording about 50 ICU meetings in the Seattle area. And the mean conference time was about a half hour. And in this study, family members only spoke about a third of the time. And in some additional analyses that they did, the more families spoke as a percentage of the meeting, the more they were satisfied and the less they felt conflicted with physicians. And so when I'm in any type of particularly kind of sensitive communication, related to advanced care planning, goals of care, bad news. I'm kind of keeping a running clock myself to gauge how much I'm speaking versus the family, given the potential risks from this imbalance. Next slide. And I'm hoping that this time you're going to take away and feel like it's really practical in terms of some skills to try out. So how do we address this risk of imbalance, clinician, patient, family? There are a couple of communication principles that I want you to take from this time. One is called ask, tell, ask. And so often what clinicians are doing in a visit is tell and maybe interspersed with some ask, but starting with an ask helps build that relationship, helps demonstrate that we as clinicians really are wanting to listen and help share the agenda. And so as an example, what ask can entail is asking a patient what their understanding is of how they're doing, what's going on with their cancer, asking what questions they have. Because again, we may have a perception of how the visit should go, but if we start with asking what questions, that may really key us into what's on that patient's mind. And it gives us a sense of, have they looked at their study results, which is very much, the norm these days. What emotions, as I'll talk about later, are they bringing in? What is their literacy level? Where do they want to take that visit? And so that helps frame things. And then the tell that we share in response hopefully has as much straight talk, straightforward language as possible, and really thinking about it as kind of morsels so that we're not going on any kind of soliloquy, trying to eliminate medical jargon. And then the subsequent ask can be what I would call, or others call, a teach back, in terms of checking in. I've shared some based on your question. I want to make sure that you're understanding, that you're on board, because I may not speak so clearly. Please tell me what you're taking away. Or if you feel like the patient is with you, you can ask and move on to another topic. And so this ask, tell, ask can be basically a cycle or an iterative process in a follow-up clinic visit, new visit, whatever the circumstances. Next slide. I think the other principle beyond ask, tell, ask is tell me more. And I often use this as a strategy when I'm stuck in terms of not quite knowing where the patient is. I'm feeling like things may be off track, or I really want to try to get under the hood, so to speak, about the patient's experience. And so, for example, with a situation where a patient may say, do everything, we all may have a consensus of what that looks like, or I don't want to be a vegetable, but people really can be individualized about what everything actually is. And so what I really try to do is not jump to assumptions and say, boy, that's really important what you just said, and I want to make sure that I'm understanding. Can you tell me more what you mean by that? And so by using tell me more, it can help deepen the conversation, because initially what patients, particularly in challenging visits, dealing with cancer, may be trying to process what on a sort of information level is happening, but then it's how they feel about it. And then thirdly, it can be scary stuff in terms of, what does that mean for me in terms of prognosis, in terms of my future? And so tell me more gives someone an invitation to get beyond the superficial to some of those deeper levels. Next slide. So first premise is that clinicians talk too much compared with patients and families. The second premise is that emotions are what drive challenges and even conflicts that our patients and families experience. It's not a lack of information or the right information. And so what I have been taught and now share with you all is thinking about emotions as data. We sometimes can be fearful that there may be a Pandora's box in terms of when emotions are shared, can we put the genie back in the bottle? What's going to happen? But to really realize that just like a blood pressure reading or a lab result, we may not have the ability to fix that, but we want to know what it is so that we can help support that person and steer them to the professional who may be the person who can address their need. Perhaps it's us in the moment, but often it's going to be a colleague. And so handling and assessing emotions are just incredibly important opportunities for empathy, to connect with patients and families, to help build those relationships, and then can also help address potential mistrust that patients may bring to the encounter. Next slide. So there are going to be a few techniques or strategies to use, and one is the nurse mnemonic, and that stands for naming, understanding, respecting, supporting, and exploring. And there's probably no surprise that it's a nurse mnemonic and not a doctor mnemonic in terms of nurses' relational skills with patients. And this is a book that I also highly recommend, that was published now over 10 years ago by the founders of Vital Talk. Next slide. So name the emotion to me is such a core principle. And I try to start with self-awareness as to when I'm in a situation, what emotions am I feeling? Because that helps me, manage how I'm behaving. But in terms of patients and families, so important to try to name the emotion. And it's not telling them how they feel by any means. That is absolutely not what I'm aiming for. But it's to float a hypothesis in terms of, boy, in terms of what you're sharing, it sounds like, or I'm sensing that you are, or other people in this situation have been, and that's where the naming comes in, frustrated, angry, scared, whatever it is. And in my experience, when I make that attempt genuinely, there is a connection, even if patients disagree. And in fact, they will often fill in the blank for me. They may say, no, I'm not angry, I am. And they may then share the emotion or more that they're dealing with. And you may, hopefully this feels validating, that particularly when there's a lot of heat or anger, until a clinician names that, someone is going to ratchet up what's their emotion because they are not feeling heard. And I'm not saying that naming that anger makes it all go away, but it generally helps bring down the temperature in the visit at least a little bit. Next slide. So naming, understanding is, again, not to say, I know how you feel, but to say, you know what, I'm really trying to understand your perspective, or I recognize, how difficult it can be being where you are. It's not, telling people premature good news, but it's validating, because when people are expressing emotion, they may feel embarrassed, boy, I shouldn't feel this way, or I'm sorry that I'm acting this way. And so, validating that it is okay, normal to kind of be where they are, and that you recognize the challenges are important. Next slide. And then respecting, absolutely. Again, I referenced before that this is something that's super important. And then again, to be able to match the intensity of how someone's feeling, with what the patient is bringing. And so, for example, even in a situation, where someone is living with stage 4 cancer, but they get encouraging or stable scan results and they're in a good place, matching that emotion and helping to sort of celebrate, even if what the big picture is in terms of prognosis, respects where that person is at the time. And this is often really helpful for caregivers to show respect for what they are offering to the patient, and they may be struggling, but to sort of validate that, they are doing a good job, they are helping their loved ones, because Certainly, they may not feel that on a day-to-day basis and are carrying quite a load often in terms of what they're responsible for. Next slide. So addressing emotions, particularly with the nurse mnemonic. The other principle that I employ really quite liberally are wish statements. And there's a classic paper that I referenced here. I essentially never say to a patient or a family, I'm sorry, because that can be confused, misunderstood as an apology or pity. You know, here I am, although I don't wear a white coat, I'm the one on the other side of the situation, as opposed to, you know, this could be any of us. And often sorry helps end a conversation versus a wish statement, which really says, you know, I wish the treatment had been more effective, or I wish the news were different, that we truly are on the same side of the table, so to speak, as that patient and family, that we wanted the same thing, but we're certainly not, you know, the wish statement doesn't say that we're going to be able to get them there. And in fact, it may basically point out that we can't get them there, but that we are on their side. And so I am often finding myself using wish statements, unfortunately, for individuals who are living with advanced cancer. Next slide. Next question. Having end-of-life care discussions with patients with advanced cancer, A, decrease their risk of having depressed, sad, terrified, and worried feelings. B, has no effect on their risk of having those feelings. C, increases patients' risk of having depressed, sad, terrified, and worried feelings.
We're getting 100% A.
All right. You know, I am a terrible question writer. Because the correct answer, which I'll share on the next slide, is A, if we could move on. So, and I think, you know, there is, I imagine among our colleagues, again, this question of, boy, I'm going to be talking about some tough stuff, and we're going to get into advanced care planning shortly. That's going to take away their hope. That's going to scare them. From what we know, communication doesn't harm patients. And this was a study done by an investigator in Boston. It was a part of a study of over 300 patients with advanced cancer and their caregivers. And at the start of this study, about a third of the patients reported having what was defined as an end-of-life care discussion with their physician. And what this study demonstrated is, having had that discussion, there was no linkage, no association with depressed, sad, terrified, or worried feelings. And I think that's a really important takeaway. Now, again, if we approach things crudely, we certainly can risk damage emotionally to our patients. But again, when handled as a procedure, you know, sensitively, there is no association. And in fact, there was a positive association and acceptance that the person's illness was terminal. And we focus a lot in palliative care oncology with prognostic understanding. There was an association with preferring care focused more on symptoms than life prolongation, an association with having a DNR order, and fewer what were considered aggressive medical interventions. So again, communication wasn't hurting people and actually was impacting decision-making and care, not just for the patient, but that final bullet in terms of caregivers, those caregivers whose loved ones had aggressive care, chemotherapy, you know, in the weeks before death, hospitalizations closer to death, ended up having a higher risk of depression, a sense of regret, feeling unprepared. So again, it's not just patients, it's families. That could be absolutely a separate topic in and of itself. Next slide. So as we start to pivot from kind of general principles to advanced care planning, I can't help but share some what I would propose as kind of words to avoid. You have failed treatment. No patient fails. The treatment fails them. The treatment hasn't been effective. And I try to emphasize, despite all you have done, despite all that your loved ones have done, withdraw care. That it just drives me bonkers. We are never withdrawing care. We may be stopping treatments that aren't helping anymore or burdening someone. We may be changing the focus of care. Comfort care only, again, to me, feels limiting. We in palliative care tend to emphasize intensive comfort care. We're trying to steal the ICU moniker and label it in terms of what we're doing, which for any of you who have had the privilege of caring for someone receiving hospice care, there's a lot of intensity. It may not be in an ICU setting, of course. Again, nothing more I can do. Absolutely, including those of you who are directly in oncology practice, there's a lot we can do to promote comfort and dignity aside from cancer-directed treatments. This is a little bit of a bugaboo in terms of clinicians who say, I'm going to send you to hospice as if it's some destination. But what I try to emphasize, again, separate topic, but hospice will help each day be the best day possible. And then we're not going to speak specifically about code status, but this notion of should we restart your heart as if people have a choice as to whether they are going to live or die versus providing a recommendation for those who are living with advanced cancer who we know have a vanishingly small, if not zero, chance of benefiting from CPR. For us, once we have a sense of what their goals are, to provide a recommendation that may alleviate their own or their family's burdens. Next slide. So what I would ask you to take to the bedside or to the clinic is to leave our agendas at the door in terms of what we think may be the sort of best decision, but to really engage authentically in sharing the agenda through Ask, Tell, Ask. It truly does not take more time. In fact, I think it can help streamline visits. Tell me more can help deepen that conversation. That yes, there is information, and certainly you all who are in oncology practice have that responsibility to share information, but it has to be balanced with emotional support, particularly if there are issues related to conflict. That communication is a process, that these are rarely one-off situations. Particularly the privilege that I have in the clinic is to build those relationships over time. And then as I'll share in the next section, absolutely important to document some of this content, ideally in an advanced care planning note, so that whether it's me trying to remember from one visit to another, whether it's my oncology colleagues, or if unfortunately a patient ends up being admitted to the hospital, that there is some information that's going to be helpful to those in the future providing care. Next slide. So I want to switch gears because if you are in clinic practice, there's, I think, increasing attention to advanced care planning as a skill, metric, even quality goal. And Rebecca Sudori, who I referenced here, is really a national leader in this field. And I'm just going to kind of quickly read this. Advanced care planning is a process that supports adults at any age or stage of health in understanding and sharing their personal values, life goals, and preferences regarding future medical care. And the goal, again, is for people to receive care consistent with their values, goals, and preferences, what I would call, and my colleagues call, goal concordant care. And so for many people, this process includes choosing and preparing another trusted person to make medical decisions in the event that the patient themselves cannot make his or her own decisions. Next slide. And so there's a tension somewhat between advanced care planning, because if you, we won't go back to the other slide, but it didn't mention any paperwork. but there are documents, advanced directives. One is a healthcare proxy, and then the other main one is some version of a living will. I put in the website to the North Carolina specific version. I'm going to share a few slides about the version that I prefer called Prepare for Your Care, but there are others that are available. Next slide. And so what I really want to emphasize is that there has been a shift from thinking about the goal being obtain an advanced directive, ideally get it into the chart. I'm not saying that's unimportant, but more focused on the planning part, that again, it's tied to communication. And the study that I'm going to reference with a few slides is this notion of preparing patients and their surrogates or proxies for in-the-moment decision-making, that there's not a piece of paper that people are going to be able to pull out in any shape or form and say, oh, I have exact instructions as to what to do in this situation. That there's a fluidity, there's a lack of ability to predict. And so we want that individual or their family to have the ability in the moment to help. And so it is more clinical versus legal documentation that we all can take on. There needs to be respect for how approaches may be quite diverse among the patients and families we care for. I think another piece that's really important is that patients and families are often, not always, but often waiting for us to bring this up. They may think that, the doctor, the APP, they're going to know when it's time to start talking about this. And it can be scary. And they may be thinking about it, but, it brings it real if it comes out of their mouth versus waiting for their clinician. And so again, to me, the takeaway from this is we want someone's care at all times to be aligned with their goals. And that's an expression that we value that person's life. Next slide. So the framework that I would ask you to kind of take away is, one, to ask permission. And that's actually a skill that I could have put in a general communication sense, because I don't want people blindsided when I get into this topic. They may feel like they're there for, to come get their cancer treatment, or for me to come get symptom management. I want to get their attention. And if they're not in a place where they want to discuss something and it's not urgent, I want to give them that power. I think the next step is, which I try to do pretty universally when I'm first meeting a patient in our cancer clinic, is to try to identify and ideally over time involve their preferred proxy. As I'll share, we want to also consider whether that individual wants their surrogate to have leeway when it comes to decision making, and I'll define what that is. We want to clarify their understanding of what their health is like and what their prognosis is. We then can explore what their goals and values are when it comes to the cancer or the serious illness they're living with. And then finally translate this communication into a care plan that remains as consistent with those goals as possible. Next slide. So I'm not going to read this, but this is from this paper about in-the-moment decision-making. And the first part is asking permission. The second part is trying to normalize this in terms of, even for people with advanced cancer, particularly the many who are feeling well, they may feel like, why are we talking about this now? And what I try to emphasize is, as the middle section talks about, this can be a gift to your family members to be able to talk about this, so they are not in the dark if they need to make decisions for you. It helps you for people where it's important. If you have a sense of what matters to you, you can help exercise control even at a point where you're not able to speak for yourself. Those are important takeaways. Next slide. And so I really do emphasize, to me, this step one. It is really important to be able to choose someone who is an appropriate surrogate or proxy decision maker. And what I emphasize is, what I say is, at all times, we are going to try to speak with you. But if you're ever in a situation in the future that you're not able to speak for yourself, who would you want us talking to? And really trying to get a sense of, who that person is. I just met someone yesterday with stage 4 cancer who has in mind a friend, but they've never spoken yet, and not someone who has other close relatives. And so this is starting the process with that person in terms of, boy, it's really, if it's possible, important for you both to have a conversation at some point down the line. Next slide. And then this, I assume all of you are in North Carolina, this is more for reference, but this is the healthcare decision-making hierarchy that is in North Carolina law. So at the top is the patient. The second section, which is in some sort of blue, is what is defined by legal documentation. So healthcare power of attorney or proxy, guardian, or people that have a general power of attorney. And then the third is, spouse, and then down the line. And certainly sometimes what I'm communicating with someone is, I'm not sure if you're not sure that you want your, kids making this decision for you, then it's important for you to choose and complete a document that spells out someone else. If you're totally fine with your spouse being that person, it's not required by any means by law to have it complete. It may give you peace of mind to make that clear, but that's who we're going to go to first. Next slide. And so I wanted to share this concept of leeway because it actually is in all forms of advanced directives. And as best as I can tell, it's actually based on a now 30-year study that was done of 150 patients who were receiving dialysis. And the question that they were asked is, would you want to stop dialysis or continue dialysis if you had advanced dementia? And the subsequent question was, how much leeway would you give your family and clinician to override your advanced directives if they felt that that was best for you? And so if you look at this, a little more than a third said no leeway at all. I have a directive, follow it. But my goodness, at the bottom, a third said complete leeway. I've got a document, I signed it, but if my spouse, preferred decision maker with my physician, thinks that a different path would be better, ignore that advanced directive. So again, to me, this emphasizes how important communication is, that the document can be a tool, but by no means is going to replace communication. Next slide. And so there are questions, again, that I won't read, but you have the PDF to really be able to dig a little bit as you get to know someone, to be able to say, if there was a recommendation that was different than perhaps what you're thinking now, would you give your loved ones the permission to make different decisions for you? Next slide. And this is the North Carolina specific living will. And this orients you to realizing that that concept of leeway actually is here. And so if you have a patient who has gone to the lengths of completing a living will, I think it's really important to tell me more, explore, particularly, if they say that my healthcare agent has the authority to override this directive, where are they coming from? Next slide. So here are some additional probes to help clarify goals and preferences beyond who a preferred surrogate decision maker is that can relate to advanced care planning. And so part of it is, does someone understand that they're living with a cancer that ultimately cannot be cured if you're caring for someone with a malignancy? But even just some very open-ended questions such as what's most important to you? What hopes do you have, or Conversely, what worries do you have? And then what I try to ask, not necessarily at all in an initial visit, but once I have a relationship with someone is, do you have any strong preferences about your care? And some people will say, absolutely. And I sit down with my family every Thanksgiving and tell them, and others will give you a deer in the headlights in terms of what do you mean? And then finally, again, because so many people lack the capacity to make their own decisions towards the end of their life, so important to try to understand, has there been discussion between that individual and their family about what's most important to them, hopes, worries, because in the end, I don't want to be on my own with a family not having had any sense of where that person is in terms of their goals and preferences. Next slide. So important, again, that this doesn't just stay in the ether of the clinic room or of the hospital room. It needs to be translated into more tangible action. So one, which I'll refer to as an advanced care planning note, which is increasingly available in any electronic medical record, certainly Epic. It's quite available. I will refer to the medical orders for scope of treatment, and then the particular living will that I would ask for you to think about, using in the future, called Prepare for Your Care. Next slide. So final question. Let's see if we got 100% here. To submit a billing charge for an advanced care planning discussion that's documented in a patient's medical record, which of the following must be true? That an advance directive, A, must be completed as a result of the discussion, B, the patient must have a prognosis of 6 months or less, or C, the discussion must be documented as lasting at least 16 minutes in duration. So perhaps a harder question.
I was just about to say, people are being, have to think about this one more.
So the majority rules again. The correct answer is C. And A, actually in the statute in Medicare, you will see reference to advanced directives, but it is not required that advanced directives be discussed or certainly completed. And that is unfortunately an understandable misunderstanding that some people have, as well as absolutely independent of prognosis. So let's go to the next slide. So to complete an advanced care planning note, it does not have to have any duration time-wise. So it just needs to document any content of what was discussed. It does not require that any decisions are made. I will share here the CPT codes, which are accessible certainly in Epic if that's what you use. And what it talks about is it's got to be explanation, discussion of advanced directives, but other topics as well. And the way Medicare works is literally there has to be documentation that 16 minutes of time were required. Don't quote me on all the specifics. If you have specific questions, you can go to whoever assists you with billing. I don't document the specific time in terms of 2 o'clock to 2:16, just that it was at least 16 minutes, and that if conversations last at least 46 minutes, there's a different code, 99498, and theoretically, multiple advanced care planning discussions can happen on a single day, but there needs to be clear documentation of how they were different. It doesn't have to involve the patient. It can involve their family members, but there needs to be clarity as to why the patient couldn't participate. There are ways to modify. It's possible to do an advanced care planning note separate from a clinic visit. So if you've done an exam, history taking, decision making, but also did an advanced care planning discussion of 16 minutes or more, you can modify the E&M code. And for all that I just shared, it was only about 2% of Medicare individuals who had a billed ACP note now about 5 years ago. That number is increasing. And to me, especially with all the note bloat in Epic, if this content is not in an advanced care planning note, it can be really hard to find, and it is too important not to be able to find. And so really, for those of you who have access to having a separate ACP note, very much encourage you to use it. Next slide. So to me, when to think about completing it, if there's any content related to your discussion with an individual about their condition, their prognosis, their care options, anything related to decisions, even if no decision was made, challenges the person was having. Again, as I alluded to, I see this note as a baton that can be passed among clinicians or from visit to visit with the same clinician. And as well, if it's a 5-minute discussion that I'm having with a patient, I try to have it in an ACP note, even if it's not something that I'm going to bill for. Next slide. So prepare for your care, and I put the website out. To me, is a really patient and family friendly living will mechanism. And the reason that it was created was the traditional, and I would argue, including the North Carolina specific living will, doesn't take into account the needs of people with different backgrounds, including low health literacy. And so I won't read this, but these are the elements of Prepare for Your Care. There's a website with videos. I don't tend to use that with patients, but there is an easy to read advanced directive. Next slide. And so they did a randomized trial of this website and advanced directive. And just to highlight it, it was 4 safety net clinics that were out in San Francisco, almost 1,000 patients, all over 55 with various chronic illnesses. And they gave them the Prepare for Your Care sort of website plus the advanced directive. And what they found was that the documentation of advanced care planning increased from 30, about a third, to over 40%. So it was significant in terms of using this approach. Next slide. And so this is what it looks like. You can access this, at least at UNC. This is certainly a directive that's appropriate. Part 1 just gives information, basic information for people about who a good decision maker is. Next slide. Part 2 asks people to think about what matters most to them in life, that quality of life differs for each person. And so it gets them thinking about what's important to them, both in terms of how they feel today and then at the end of their life. Next slide. And this is, again, an example where it asks people, in your current health, put an X on this line where on the left-hand side, it's my goal is to live as long as possible no matter what. And on the far right, it's my goal is to focus on quality of life and being comfortable, or somewhere in between. And then it asks someone to, if they could envision the end of their life, would they feel any differently? Next slide. So strategies to improve advanced care planning is that this is not just for individual clinicians, but our entire teams can engage in advanced care planning. We need to be more flexible and certainly sensitive to different cultural needs, support our surrogate decision makers who may feel like they don't know what their role is, and then to try to make documentation easier. During the pandemic, they suspended the requirement of a notary in North Carolina, but that's now required again. Next slide. So again, as I noted, we want to not just have it be a physician or even an APP task, but the nurses we work with, social workers, even lay navigators can have a role. And there is training available by various resources. Next slide. And then absolutely want to note, and this would be an important topic in and of itself, that there are inequities associated with race and ethnicity that compared with white patients, African Americans and Latinos are unfortunately more likely to die in the hospital, less likely to utilize hospice, less likely to complete advanced directives, and I would say less likely to engage in advanced care planning. And so we need to have more flexible and approaches that demonstrate our cultural humility, as well as trying to partner with religious and civic groups that have trust in different communities. Next slide. And then finally, my last slide is, I think overall the spirit in general, but specifically related to advanced care planning, is to seek to know patients and their families as individuals, as people, to be dedicated to their quality of life and care, and to try to manage our biases throughout the process. And in practice, that includes identifying their preferred surrogate decision maker, being able to discuss at various intervals their understanding of their condition, what their current and future goals are, to complete advanced care planning notes related to our discussions, to consider whether completing a document is going to be in that patient's best interest and to offer that, but certainly not make them feel like it's required. And then again, in the clinic setting in particular, this is not a topic, advanced care planning, that I talk about each visit. I try to be intentional about at what intervals am I going to check in with patients, and certainly want to let them know that I'm available for advanced care planning discussions at any point if they should so choose. That's it. Thank you so much.
Thank you so much, Gary. This highlights just the reasons why I asked you to do this talk. So much I've learned from you, was highlighted in this talk. While we wait for questions to come in, please everyone send them through Poll Everywhere. Get your questions in. But while we wait for them to come in, as providers, these could be pretty heavy talks, right? They're heavy talks for the patients and can be, weigh pretty heavily on our providers. So I think you should share where the highest peak in Orange County is. So when people are feeling the weight of caring for cancer patients, they can get out and do some forest bathing and soothe their soul.
Absolutely. I'm just looking at, I have a hard time pronouncing it, but it is the Occoneechee Mountain. It's actually called a mountain, very close to actually downtown Hillsborough. So lovely view of the Eno River.
Yeah, great. Yes, I have hiked that as well. It is a beautiful place. So everyone should check it out. So one question that did come in through the chat, as a provider or, someone helping care for the patient is speaking with, a patient, and you notice some discrepancies in what the patient understands or what has been addressed with the patient, then what, say, the primary team member or the primary provider has talked with the patient. How do you address that either yourself or with that provider? I think the question is coming in from, healthcare team member communication.
Yep. And I think, and certainly we all have different roles. My role is as a consultant. I am not obviously an oncologist, a cancer provider, but I think the role that I can have, and it sounds like based on the question that others can have, is to respectfully but clearly communicate the patient's concerns to the oncologist, and hope that lands for that person in terms of, I certainly recognize that there is so much that is packed in to an oncology clinic visit, and that patients may well share emotions, fears with me that they are not comfortable sharing with their oncologist out of concern that they might not get chemo that day, or it's going to affect their treatment. And I suspect that you all as APPs, although you are administering treatment, you may get some of that same type of interaction with patients. And so I do think that that's something that's a responsibility, and hopefully as colleagues, there's going to be space and time, for that oncologist to be able to process that.
Great, thank you. And our last question, do you feel like you are still learning and improving your communication skills as time goes on?
Oh my God, 100+%. And actually for me, the privilege has been, we have physician fellows who are training in palliative medicine. And so that forces me to try to be on my top of my game. But also for me, I'm very privileged to, from time to time, have joint visits with oncologists and patients and families. And so I learn a lot from those interactions. So to me, this is definitely a lifelong process.
The next question is suggestions on approaching a patient with metastatic cancer who is not a candidate for additional treatment due to performance status labs that is not ready to stop chemo.
Yeah. So I think to me, it's, from my perspective, it's trying to understand, again, it truly is kind of a tell me more in terms of, why are they not ready? What is, are there fears? Is there a concern that they're going to feel like their family or even their oncologist feels like they're giving up? So I think that's an important factor. And then I think from my perspective, it's also supporting the oncologist in communicating that to the patient, because again, I recognize how difficult it is for the oncologist to provide that assessment. And so making sure that that patient or family knows that stopping chemotherapy does not mean stopping treatment. And so whether it's continued clinic visits for monitoring, phone calls or videos, or, to me, it's there's such an intensity in relationship that builds, that not having someone feel like because they've stopped treatment, they're stopping care. So I think that's another piece.
Great, thank you. And then our final question is, how do you or how should you handle if this specifically is calling out the doctor doesn't seem to have the patients to talk or explain the way the patient may need. So I'm assuming this is talking about another provider that's part of the care team and may notice some communication challenges there.
Yeah. I gave much easier questions that you all are giving me. So turnabout is not fair play here. I mean, I think that that's a multi-layered question. I'll try to answer it, which I think some of it is what I do in terms of trying to facilitate communication. And again, you all as APPs have important roles in this too, is literally like trying to ask the physician their sense of where the patient is. So because again, they may be genuinely, obviously wanting to do the best for that person and have a perspective that for whatever reason, you're getting a different signal. And so I think some of it is to not make assumptions at all that the person, doesn't have the patience. Certainly it's possible, but sort of where is that oncologist coming from? And are they open to, hearing your perspective? Because I think, 9 times out of 10 or more, that individual physician wants to know if someone else on the team is getting a different sense of where that person is.
Great, thank you. So we ended on that, challenging note. So thank you for your time today. This was really important information to share. So thank you. So thank you all for attending. Thank you to our team at the Lineberger Cancer Network. Without them, this would not be doable. So thank you to Tim Poe, our director, Mary King, Benny Abior, John Powell, Oliver Marth, Jason Paler, and Andrew Dodson. You guys worked tirelessly to make this all come together. So thank you. There's a lot of behind the scenes work. Next slide. Upcoming lectures, our one and only Mary Dunn, a fellow APP, will be talking about testicular cancer in our patient-centered care. Research to practice, the next lecture is on radiation oncology. And our next APP lecture is on cardiotoxicity of cancer therapies. So put them on your calendar, tune in. Next slide. Remember, all of these lectures are posted on the website, can be viewed later on your own time. You can still obtain continuing ed credit. Our most recent lectures were oncologic emergencies, our breast cancer management, and the thoracic surgical oncology. So check them out on the website. Next slide. So thank you again for participating. Don't forget to fill out your evaluations and get your continuing ed credit, and go to the website, unclcn.org. There's a wealth of information, and I hope you all have a great night. Thank you all.